Hello everyone, welcome to another nephrology lesson. In my today's lesson, I'm going to talk about isolated glomerular disease with recurrent gross hematuria. The content of the presentation is about immunoglobulin nephropathy, Alport Syndrome, thin glomerular basement membrane disease. To start with IgA nephropathy or Berger nephropathy, it is the most common chronic glomerular disease in children. It is an immune complex disease initiated by the excessive amount of poorly glycosylated IgA in the serum. There are familial clustering of the IgA nephropathy. IgA nephropathy is an immune complex disease which is initiated by excessive amount of poorly glycosylated IgA in the serum. That means, for a unknown reason, which have some complex polygenic disease with genetic predisposition, their body produces abnormal IgA and their body recognizes those things as a foreign, causing the production of IgG and IgA autoantibodies. Then they form immune complexes in glomerular and deposits in the mesangial area. This causes inflammatory reaction at the site and causes glomerular injury. When we came to clinical and laboratory manifestations of IgA nephropathy is seen more often in males than in female patients. Although there are rare cases of rapidly progressive forms of the disease, the clinical presentations of childhood IgA nephropathy is often benign in comparison with that of adults. IgA nephropathy is an uncommon cause of end-stage renal disease during childhood. Majority of children with IgA nephropathy presented with gross hematuria, whereas other presentations include acute nephritic syndrome, nephrotic syndrome. Also, combined nephritic and nephrotic pictures may be seen. Gross hematuria often occurs within 1 to 2 days of onset of an upper respiratory or gastrointestinal infection, in contrast with the longer latency period observed in the post-infectious glomerulonephritis, and it might be associated with lung pain. Mild to moderate hypertension is often seen in patients with nephritic or nephrotic syndrome, but it's rarely severe enough to result in a hypertensive emergency. And also, normal serum levels of C3 in IgA nephropathy helps to distinguish this disorder from post-infectious or post-streptococcal glomerulonephritis. But serum IgA levels have no diagnostic value because they are elevated in only 50% of pediatric patients. When we came to the treatment part, although IgA nephropathy does not lead to significant kidney damage in most children, progressive disease develops in 20 to 30% of adults 50 to 20 years after disease onset. Therefore, most children with IgA nephropathy do not display progressive renal dysfunction until adulthood, prompting the need for careful long-term follow-up. Poor prognostic indicators at presentation or on follow-up includes persistent hypertension, diminished renal function, significant increasing or prolonged proteinuria. Those things are poor prognostic indicators of IgA nephropathy. A more severe prognosis correlated with histologic evidence of diffuse mesangial proliferation, extensive glomerular crescentus, glomerulosclerosis, and a diffuse tubulointerstitial damage, including inflammation and fibrosis. The primary treatment of IgA nephropathy is appropriate blood pressure control and the management of significant proteinuria. Angiotensin converting enzyme inhibitors and angiotensin 2 receptor antagonists are effective in reducing proteinuria and retarding the rate of disease progression when used individually or in combination. Fish oil, which contains anti-inflammatory omega-3 polyunsaturated fatty acids, might decrease the rate of disease progression in adults, and also it can be used in pediatrics. If a renin-angiotensin system blockage proves ineffective and the significant proteinuria persists, then addition of the immunosuppressive therapy with corticosteroids is recommended. Corticosteroid reduces proteinuria and improves renal function in the patients with GFR greater than 60 ml per minute per meter square. And also, tonsillectomy has been used as a treatment of IgA nephropathy in many countries. Performing a tonsillectomy in the absence of significant tonsillitis is in association with IgA nephropathy currently is not recommended, since there is no adequate evidence that shows it is helpful. Patients with IgA nephropathy may undergo successful kidney transplantation, although recurrent disease is infrequent. allograft loss caused by IgA nephropathy occurs in only 50 to 30% of patients. The second one is Alport syndrome. Alport syndrome was named after 1927 when Dr. Cecil Alport published a paper describing the association of kidney disease and deafness in affected individuals. Alport syndrome is it is called hereditary nephritis by another name. It is a genetically heterogeneous disease caused by mutations in the genes coding for type 4 collagen, which is a major component of glomerular basement membrane. Those genetic alterations are associated with marked variability in the clinical presentation, natural history, and histologic abnormalities. Approximately 85% of patients have X-linked inheritance caused by the mutation in the genes encoding the alpha 5 chains of type 4 collagen. When we came to the pathology, kidney biopsy specimen during the first decades of life will show only a few changes on light microscope. Later, the glomerulus may develop mesangial proliferation and the capillary wall thickening, leading to the progressive glomerular sclerosis. Tubular atrophy, interstitial inflammation, fibrosis, and the lipid containing tubular or interstitial cells called foam cells develop as the disease progresses. Immunopathologic studies are usually they are not diagnostic. In most patients, electron microscope reveals diffuse thickening, thinning, splitting, and layering of the glomerular and the tubular basement membrane. To confirm the diagnosis, the ultrastructural analysis of the glomerular basement membrane in all genetic forms of Alport syndrome might be completely normal, displaying the non-specific alterations, or demonstrate only uniform thinning. When we see the clinical manifestations of Alport syndrome, all patients with Alport syndrome have asymptomatic microscopic hematuria, which might be intermittent, but single or recurrent episodes of gross hematuria commonly occur 1 to 2 days after upper respiratory infection, or it's in approximately 50% of patients. Recurrent hematuria after upper respiratory infection is seen around 50% of patients. Proteinuria is often seen, but it might be absent, might be mild, or it might be intermittent. Progressive proteinuria severe enough to cause nephrotic syndrome can be seen later in life. Bilateral sensorineural hearing loss, which is never congenital, develops in most patients with Alport syndrome. This deficit begins in the high frequency range, but it progresses to involve the hearing associated with normal speech. This prompts the need for hearing aids. This progression of hearing loss seems to run parallel to the loss of renal function. Ocular abnormalities, which occurs in 30 to 40% of patients with X-linked Alport syndrome, includes anterior lenticonus, that means extrusion of the central portion of the lens into the anterior chamber, macular flex, and also corneal erosions can occur. When we see the diagnosis of the Alport syndrome, it's a combination of a thorough family history, screening urine analysis of first degree relative, and also audiogram and ophthalmologic examinations are critical in making the diagnosis of Alport syndrome. The presence of anterior lenticonus is pathognomic. Anterior lenticonus, it is very peculiar finding in patients with Alport syndrome. Alport syndrome is highly likely in patients who has hematuria and at least two of the following characteristic clinical features: macular flex, recurrent corneal erosions, glomerular basement membrane thickening, and also thinning, and sensorineural deafness. The absence of epidermal basement membrane staining for the alpha 5 chains of type 4 collagen and the discontinuous epidermal basement membrane staining on skin biopsy is pathognomic for X-linked Alport syndrome, and this can preclude a diagnostic renal biopsy. When we see the treatment, the risk of progressive renal dysfunction leading to end-stage renal disease is highest later in life in certain patients. Risk factors for progression are gross hematuria during childhood, nephrotic syndrome, and prominent glomerular basement membrane thickening, and no specific therapies available to treat Alport syndrome. Also, angiotensin converting enzyme inhibitors and possibly angiotensin 2 receptor inhibitors can slow the rate of progression. Careful management of renal failure complications such as hypertension, anemia, electrolyte imbalance is critical. Patients with end-stage renal disease are treated with dialysis and kidney transplantations. Approximately 5% of kidney transplantations recipients develop Anti-glomerular basement membrane nephritis. Screening of heterozygote carriers for significant renal disease later in adulthood, and the possibly treatment for significant proteinuria is also recommended. The other topic is thin basement membrane disease. Thin basement membrane disease is defined by the presence of persistent microscopic hematuria and isolated thinning of the glomerular basement membrane on electron microscope. Microscopic hematuria is often initially observed during childhood, and it might be intermittent. Episodic gross hematuria can also be present, and particularly after respiratory illness. Isolated hematuria in multiple family members without renal dysfunction, which is referred to as benign familial hematuria, is often presumed that the underlying pathology is thin basement membrane disease. Thin basement membrane disease might be sporadic, or it might be transmitted as autosomal dominant trait. Heterozygous mutation in genes which encode the alpha 3 and alpha 4 chains of type 4 collagen presented in the glomerular basement membrane results in thin basement membrane disease. Rare cases of thin basement membrane disease progresses, and such patients develop significant proteinuria, hypertension, and renal insufficiency. So consequently, monitoring patients with benign familial hematuria for progressive proteinuria, hypertension, renal insufficiency is important throughout childhood and young adulthood. This is the difference between normal glomerular basement membrane and also glomerular basement membrane in Alport syndrome and the thin basement membrane lesion. In thin basement membrane lesion, there is a thinning of the glomerular basement membrane as compared to that of the normal glomerular basement membrane, whereas in Alport syndrome, there is abnormally split and laminated glomerular basement membrane. Thank you. Don't forget to subscribe and like, and also you can comment.